Well, thank you very much for joining us, and we really enjoy having everybody around here. Today, we're going to have a very relevant discussion about the association and the making a diagnosis, differentiating a sinusitis from a migraine. And I think everybody have recognized and complimented Dr. Loftus' discussion, and I think you'll find it very, very clinically relevant. So I wanted to show you this recorded session. Thank you very much, and enjoy, and I'll see you at the end of the session. Give me just 1 second. I was having a bit of an issue here. I don't understand it. Give me just 1 second. Okay. And share. I don't understand why it's not working. Give me just 2 seconds. All right, I think I do understand. Give me just a few more seconds again. All right, here we go. So hello, everybody, and thank you all for joining us. We have with us this morning for her, this afternoon for us, Dr. Patricia Loftus. Patricia, can you hear me?
Yes, I can.
That's great. Thank you very much for joining us. I know it's pretty early for you in California.
Yeah, no, thank you so much for having me. It's an honor.
That's great. So please, I'll turn the podium over to you. Please go ahead and start the presentation.
Great. I'm going to share my screen right here. Okay, is that working?
Yeah, this is great. Thank you.
Wonderful. Okay, so good evening to all of you. Good morning to me. My name is Patricia Loftus. I'm a rhinologist at the Department of OH&S at the University of California, San Francisco. I'm really excited to be here, and I feel grateful to have been asked to give this lecture, and I want to thank you all for being here. So my topic probably doesn't sound as exciting as some of the other topics listed here, but you know, I like discussing practice-relevant topics rather than, you know, esoteric surgical procedures and the like. Part of our job as otolaryngologists is to explain to our patients when they actually do not have an OH&S issue, and that can be tough for patients, especially if they were told by another physician that, you know, they were going to be sent to an ENT who was going to, quote unquote, fix their problem. But what I've found in my practice is that if I spend some time with these patients, talk about some data or some facts behind the reason that what they think may be happening is not actually happening, then you know, we come to a shared decision making about what's going on, and they trust me more, and they understand better why their problem may not be something that an ENT can necessarily help with sinus surgery. So I have no disclosures to list. And quickly, the objectives of this lecture are going to be going over the diagnostic criteria for chronic rhinosinusitis. We're going to do a quick overview of headache disorders. We'll talk a little bit about why sinus disease is overdiagnosed and about some of the overlapping symptoms between the two, CRS and headache disorders. We'll go over a few imaging findings, and we'll talk just quickly about two disease processes that I wanted to mention: recurrent acute rhinosinusitis and contact point headache. And then we will end with some tips for differentiating CRS from other causes of headache. So to begin with some background information, we all know that rhinosinusitis is a group of disorders characterized by an inflammatory response. This involves the nasal and paranasal sinus cavities. It is highly prevalent in the United States, which is where I practice, and it has an estimated effect of 4 to 16% of the adult population annually. And in this picture, I'm showing the left nasal cavity, and as you can see, it is very inflamed and edematous in here. So when we think of chronic rhinosinusitis, we think of more of an inflammatory process rather than an infectious process. Now there can be infection on top of it, of course, but that's what I am highlighting here. So some of the first diagnostic guidelines for rhinosinusitis were published by Lanza and Kennedy in 1997. And what's important here is that the symptom of facial pain and pressure alone cannot make this diagnosis of rhinosinusitis. There must be evidence of other more common sinusitis symptoms, such as nasal obstruction, nasal drainage, or decreased smell. And it should also be noted that headache is only a minor symptom, and therefore a possible rhinosinusitis diagnosis in this scenario also requires a major and another minor criteria. So of course, headache alone is not sufficient. Facial pain or pressure alone is not sufficient. And just to note, this talk will focus mostly on chronic rhinosinusitis, not acute, since chronic is really what our patients mean when they come to us and say they have persistent sinus headache. Acute sinusitis, as we know, can definitely cause headache and facial or dental pain, but this clears up in a month or less. And I would say in my practice, it usually doesn't result in a referral to me unless it becomes like a recurrent acute process, which we'll talk about a little bit. But when it's an actual acute infection, it clears up within a couple of weeks, sometimes usually less than that. So they don't usually make their way to my office. So what I'm talking about mostly in this lecture is more of a chronic picture. So this slide is from the International Consensus Statement regarding CRS. Those put out by Orlandian colleagues. So for CRS, 2 or more of these symptoms must be present for more than 12 weeks. Nasal congestion or obstruction, blockage, nasal discharge is the second one, and facial pressure and reduction or loss of smell. So 2 of those 4 symptoms must be present for more than 12 weeks. So basically what this is showing is that another symptom aside from facial pressure needs to be present. Furthermore, and this is important, inflammation or infection must be documented on exam or on imaging. So, all of this is required to make a diagnosis. Just having those symptoms doesn't necessarily make the diagnosis. You have to make sure that you have some objective evidence either on CT scan or nasal endoscopy. Let me see if this video is working. Great. So, for instance, this is a patient with unilateral facial pressure, congestion, foul-smelling drainage for almost a year after a dental procedure who came to see me. You can see the edema and the inflammation and the purulence in the left middle meatus. Right side looks relatively clear. He ended up having a left odontogenic sinusitis picture. So this is just, an example of having a positive objective finding. Same thing with this video. Looking in the nose, you see the purulence, you see the inflammation, you see the edema. So this is an example of a patient who may have come in with symptoms that sounded consistent with chronic sinusitis, but we needed to make sure that they also had objective findings, and nasal endoscopy did show that. Okay. So then there are headache disorders, which when taken as a whole are actually much more common than rhinosinusitis. So tension headache is particularly common, as is migraine, especially in the female population for the latter. So there's a lifetime prevalence of almost 50% for tension headache and 20% lifetime prevalence for migraine. What's interesting is, or something to note is the distribution. Whereas tension can equal among both sexes, migraine tends to be a 2 to 3 to 1 ratio in female. And then you have cluster headache, which overall is less common.
The sound seems to be going off a bit. Maybe are you close to the microphone?
Sorry.
Yeah, that's now you sound good. Now it sounds good.
Sorry about that. I'm going to lean in a little bit closer. Thank you so much.
That's great. Thank you.
So just quickly, in case anything was missed, I was saying how tension headache is very common, equal among the sexes. Migraine is also very common, more common in women. And then cluster headache is not very common, but it's pretty important to be aware of, because it can present with other symptoms that are suggestive, let's say, of sinusitis. So nasal congestion, rhinorrhea. Cluster headaches tend to be unilateral, which can be seen in acute rhinosinusitis. And as well, migraines can tend to be unilateral. Migraines are usually accompanied by nausea, which we don't see as a symptom of CRS. And tension headaches tend to be localized to the forehead. You see in the diagram above, kind of to the forehead and the top of the head, but they can be periorbital as well. Again, this kind of confuses the picture of headache versus CRS, because those areas do correspond to the sinuses. So true pan-sinus disease tends to affect most facial areas over the sinuses, the forehead, the cheeks, around the orbits. Patients usually say kind of around my eyes and underneath here, and sometimes they'll point to their forehead. But it's hard because this overlaps with headache disorders. But then again, there are also patients that have chronic sinusitis due to a fungal ball or a odontogenic infection, and that would be localized to one side. So again, this all makes it quite confusing. So it's good to know where these type of headaches and sinusitis may show up as facial pressure, but it's really not something that we can use to make the diagnosis, because there's a lot of overlapping findings. Another primary headache disorder to be aware of is hemicrania continua. Like cluster headache, this disorder presents with autonomic symptoms, which include nasal obstruction and rhinorrhea. But it's different from cluster headache, differentiated by its response to indomethacin. It's also more common in females, while cluster is more common in males. And overall, it's not a very common disorder at all, but it is something to be aware of, because it is something that you may see in your practice at some point within the span of your practice. And just nice to have on the back burner some some other differentials for what can be happening to these patients. And we'll talk about it a little bit more, but they will inevitably say, well, if it's not my sinuses, what is it? So you want to have a little bit of an understanding about what it could be. You don't necessarily have to make that diagnosis then and there, but patients do like to know that you're at least thinking of something else and can send them to the right person if you're not the person that can necessarily take care of it. So the American Academy of Allergy, Asthma, and Immunology notes that up to 80% of the North American population has headaches, 50% monthly, 15% weekly, and 5% daily. And interestingly, they are more common in the 2nd to 5th decades of life, which does mostly correspond to the CRS population as well. So again, that overlap that makes it a little bit difficult to differentiate. So why do patients think that their headaches or facial pain or pressure are caused by sinus disease? Here are some reasons. So, the media is a reason. Commercials, Google searches, walking through the pharmacy, you can find drugs like this. So we have Benadryl, Excedrin, Sudafed. So none of these are recommended evidence-based therapy for CRS. And some can actually treat headache disorders, Excedrin, you know, so it's confusing for patients, but it's also confusing for us as providers when these patients come to us, because they will say that they've tried sinus medication and it has helped. But you have to really break it down and say, what kind of, you know, medication did you take? Is this something that we actually use to treat chronic sinusitis? But, you know, overdiagnosis is also our fault as practitioners at times. So in this study that included over 500 patients with a new CRS diagnosis, only 30% diagnosed by an otolaryngologist and 1% by a primary care physician met the criteria that we previously discussed. So granted, a lot of the time these patients come to you telling you that it's their sinuses and explaining that they have received numerous courses of antibiotics, prednisone tapers, things like that from urgent care. But since patients with CRS tend to feel a little better with treatment and then their symptoms return once the treatment is stopped, it can be a red flag that they tell you that they tried all of these types of medications over and over, and it didn't help their symptoms at all. But on the other hand, even if their symptoms are not sinus related, prednisone, as we know, can have a positive effect on making patients feel better. So some may even say that they did respond to antibiotics and steroids, even if the headaches and facial pressure are not sinus related. So again, very confusing. But we do have data to show that most patients referred for just sinus headache or sinus pain do not end up having true sinusitis. So for instance, one study showed that about 75% of patients referred to OH&S for sinus headache ended up satisfying the criteria for migraine. And another demonstrated that 82% of sinus headache referrals to OH&S they were given triptans, and 82% of them responded, which is a very high number. So the International Headache Society does lay out diagnostic criteria for headache that can be attributed to rhinosinusitis. In this case, it's focused more on acute rather than chronic. So like we discussed the difference a little bit before. So if the headache is located in the frontal region and accompanied by pain in other regions, such as the face, ear, or teeth, then they say that that could potentially be related to sinusitis in an acute manner. But there must be physical evidence of sinusitis, either by exam or imaging, like we talked about. And the headache or facial pain should be related to a sinus exacerbation and should resolve with appropriate treatment. So again, these criteria really kind of go along more with an acute rather than a chronic sinusitis picture, unless there was an exacerbation. So, the IHS really does say that chronic sinusitis is not a validated cause of headache or facial pain unless it has relapsed into an acute stage. So that's, something that I like to discuss with my patients as well. So here's a table taken from a review by Zara Patel and colleagues that lists studies pointing to a diagnosis of migraine in patients referred for sinus headache. I don't need to go over each and every one of these studies, but just suffice it to say that they did show that most patients referred for just sinus headache or facial pressure ultimately did not have sinus disease. But as mentioned before, it is difficult to differentiate migraine and sinus-related facial pressure because, as this study shows, 80-some% of patients with migraine did report symptoms of sinus pain and pressure when they were asked. So they actually used those terms or reported those symptoms even when they already knew that they had migraine. So on top of that, there was also a high percentage of nasal obstruction, runny nose, and other allergic symptoms. So, of course, there can be overlapping pathology that patients with migraine could also have allergic rhinitis. So it makes it, even that more difficult to hash out what is going on. So maybe patients do have symptoms to meet diagnostic criteria for rhinosinusitis, but as we already discussed, that does not make the diagnosis. There has to be objective evidence of it as well. So that's done again by either imaging or on exam. So in this study, 78 patients met the diagnostic criteria for sinusitis in terms of their symptoms, but only 37 had positive findings on CT. And for those with a positive CT, it should just be noted that there was no correlation between the imaging findings and the severity of patient symptoms, which is a well-known phenomenon to anyone who practices rhinology, that the symptoms don't always match up with the objective findings. And in terms of nasal endoscopy, a normal endoscopy is a good predictor that the CT will be normal, and an abnormal is a good predictor that it will not be, which makes sense. But it's not 100%. So, I do think that out of the two, CT is really a gold standard for evidence, objective evidence of sinus disease, because, not everybody who has a nasal endoscopy will sometimes show inflammation or purulence in the nasal cavity. It may be, more into the paranasal sinuses, and nasal endoscopy may not pick that up. Obviously, when you do a nasal endoscopy and you see objective findings, then that's really good information. But if it's negative, you could still have some disease on CAT scan. So I tend to think that a CT scan is really the gold standard for objective evidence of sinus disease. Another thing to take into consideration is that many of these patients may already have undergone an MRI for their headache. If they saw a practitioner before you, so an MRI, not a CT scan. And, MRI does tend to overcall sinus disease. For example, just mild mucosal inflammation can look impressive on MRI, but on CT, it may really not be that impressive. And based on their symptoms, it may not warrant medical or surgical treatment at all. So if there is a question on MRI, whether there is objective evidence or not, you can always order a CT scan. But symptoms should be present, of course, because even in a CT scan, 30% of an asymptomatic population could have mucosal changes. So still, start with the subjective findings and go to the objective. But however, if there is an MRI within the recent past, and nothing has really changed in terms of their symptoms since they received the MRI, and it looks completely normal, then you can tell the patient that they do not have objective findings of CRS, and another reason for their headache or facial pain should be sought after. And I just wanted to mention mucus retention cysts, since we do see these and do get referrals for this as otolaryngologists. So as you know, they're obstructed seromucinous glands located in the sinus mucosa. These cysts are an incidental finding in about 10% of normal patients. They're mostly found in the maxillary sinuses. So they're very common, but as you know, they're not the same as sinus disease. So this is the same patient on the CT and MRI. What I just wanted to make note of is that I feel like, because of the contrast, or the MRI, they do look a little bit more impressive on MRI, I guess you would say, which is the point I was kind of making before. And this is not the same patient, the endoscopic view. But it's looking into the left maxillary sinus, looking at a mucus retention cyst. The surgery was performed for other reasons, not for the cyst. But what I wanted to point out is that the mucosa, the lining of the maxillary sinus outside of the cyst, is normal appearing. There's no inflammation or purulence or mucus. And these cysts usually do not block the drainage pathway of the sinus. If they're very big and, fill up the whole sinus, and maybe when they could get infected and block the drainage pathway, that might be another story, but that's pretty uncommon. They're usually not causing any issues at all. And you need to, just explain this to the patients, because they may have been told that they had a positive finding on their CAT scan, and something needs to be done about it. But, you just need to sit and explain to these patients what these are and why you think, potentially removing the cyst wouldn't make much of a difference in their care. So here are some pictures of positive sinus findings, objective findings on CT. So the first patient had a unilateral left-sided facial pressure, foul-smelling nasal drainage picture, and had a recent dental history. So we did diagnose odontogenic sinusitis in that patient. And the patient on the other side is obviously much more impressive. Diffuse facial pressure from nasal polyps, thick mucin throughout the sinuses. As you can see, all the sinuses are grayed out. So, there is this goes back to my point where, you can't really rely on where the facial pressure is to diagnose what might be going on, or even what sinuses might be affected, since the severity and disease varies widely within patients. So, these are kind of slam dunk cases, I guess, where someone had unilateral pressure and then unilateral CT findings. Another patient, had diffuse facial pressure and these findings. But then there's also kind of the in-between patient that, tends to be a tricky spot to be in. So for someone who maybe has significant facial pressure, but minimal disease on imaging. So as I mentioned before, we do know that symptoms and CT findings do not correlate. So as long as this patient had other symptoms of CRS aside from just facial pain, they had one other major diagnostic criteria that they fit the subjective criteria, and then they had this CT scan. This would be an appropriate patient for us to evaluate, and we can discuss the pros and cons of medical or surgical intervention with them. So, if this patient had tried all of the medical intervention and still had the CT scan and still was complaining of facial pressure, congestion, and drainage, it is someone that I would potentially offer intervention to if they truly understood the risks and benefits and understood that I couldn't be certain that it would help, but it potentially could. So the other thing is that, because even if these patients do have a diagnosis of migraine, there can be concurrent sinonasal disease that should be treated. So that, that's what I sometimes worry about, that I don't want to say, no, this isn't going to help, when it could potentially help. But you really have to kind of hash that out. So, I have had patients that have migraine and CRS. But on the flip side, sinus surgery can trigger a migraine or other chronic pain syndrome. So, getting a good history and having a long discussion about the realistic expectations of medical therapy or surgery is the best way to go in any case, but especially in these in-between cases. So basically what I would say is that, you treat them appropriately like any other patient who has lots of disease on scan. And if they're still fitting the diagnostic criteria, you can definitely talk to them about surgery. Because even minor mucosal changes, opening everything up, allowing them to get topical medication in there can definitely help. So I wouldn't not offer this patient surgery, but I would want them to understand that, their disease is not horrible. I'm hoping that it will help, but they need to have realistic expectations. So then, recurrent acute rhinosinusitis, this is kind of, a hot topic, and a lot of debate about how to diagnose and how to treat. But I bring it up because this is a population. I do believe that this is a thing, I guess we'll say, recurrent acute rhinosinusitis. I do believe that it is a true disease process. So I wanted to discuss it because this is a population that could potentially benefit from sinus surgery, but may have a normal CT scan if it was performed during an asymptomatic period. So it's very important to nail down the timeline of infections and ask the patient if their symptoms are chronic or if they have asymptomatic periods. And it's also important to ask them how they were feeling during their CAT scan or how they're feeling that day when you're scoping them. Because for these patients, if they describe 4 or more episodes a year with the appropriate symptoms, but they say that they feel pretty good in between, that could be a recurrent acute. And if these multiple infections are really affecting their quality of life, their productivity at work, they could be a candidate for sinus surgery. But I do still want objective evidence of this before going to the operating room. So what I like to do is tell the patient to come to my office during an acute infection so I can scope and hopefully get that objective evidence. Obviously, sometimes that's not always easy if you have an overbooked clinic. So another thing that you can consider is ordering these patients a CAT scan and say, get this done when you are feeling symptomatic. And then we can maybe document the objective findings that way. So, there's a lot that could be talked about with this, with recurrent acute, but I just wanted to quickly touch base about it and, just say that we don't want to necessarily lose these patients by just saying you have a normal CAT scan. And, kind of really delve into how many infections do you have? How did you feel during the time you got the CAT scan? Are you asymptomatic in between, that kind of thing. Another quote unquote entity I wanted to touch upon is contact point headache, because I have gotten referrals for this before. So this is when a septal spur is contacting a turbinate or the lateral nasal wall in the nasal cavity. And some people believe that this could result in unilateral headache and that headache would improve with a septoplasty. Especially when there is absence of other causes of their headache. So they've obviously failed primary headache disorder treatment or the like, and they failed, all types of medical therapy that way. So this really is a diagnosis of exclusion, because you should try everything else first. But it's also a diagnosis that really doesn't have good data behind it. So, one thing that you can potentially do to see if you think this may help is the last point where I talk about relief after targeted topical anesthesia. If you use a little cotton swab and right on the area of where the spur is contacting the lateral nasal wall, if you topically anesthetize that area, wait a little while, and then the patient says that the headache goes away, then, that is maybe a sign that doing the septoplasty will help. But, a 2013 meta-analysis found an equal number of contact points on scan in patients with and without headache. And the IHS reported limited evidence for this diagnosis. So, I have seen patients for this, and I've talked about what the data shows and kind of what they thought. Now, if the patient also has nasal obstruction that hasn't responded, like unilateral nasal obstruction that hasn't responded to nasal sprays and the like, then that's a reason to do the surgery. So I would say, I could do the surgery for your nasal obstruction, and then it would be great if it helped your headaches, but I can't tell you that doing the surgery is going to resolve your headaches. And I would say that, I have done this before for nasal obstruction, and in my limited experience of it, and maybe someone else has more experience, the headache did not go away for the patient. Their nasal obstruction was better. But I have spoken to my colleagues about this, And, they've mentioned those anecdotal cases where a septoplasty has improved a headache. And so I think it's just hard to say. And you just, tell the patients that there's definitely not great evidence to support it, but there are those cases out there where patients may have had the septum done for another reason, and they feel like it did help their facial pressure or their headache. So again, I know I keep going back to it, but it's a kind of a patient conversation. So just a few tips here. There is some recent data showing that if a patient presents with facial pain or pressure or headache as their main symptom, this has a negative predictive value that they will ultimately be diagnosed with sinus disease. So that's just something I like to tell my patients, that if this is your only symptom, there's negative predictive value that is actually your sinuses. So, the studies show that on our SNOT-22 scale that I showed on a prior slide that quantifies symptoms from 1 to 5, with 5 being the worst. The study showed that a grade of 3.5 or higher for facial pain was also a negative predictive factor for sinus disease. So you really want to be sure the patients have other diagnostic criteria before making this diagnosis. And then if they do have other symptoms consistent with a chronic rhinosinusitis diagnosis, a CT will then clinch that diagnosis, since chronic inflammation will show up like we talked about. So if there is a question of whether the patient has CRS or not, I think that is reasonable to get a CT, especially if they've been treated already with rinses and Flonase and things like that. Or if they haven't been treated, I think it's reasonable to follow our typical algorithm that I will show in a bit of saline rinses and an intranasal corticosteroid, and see how they respond. If they respond well, then they can continue this treatment without a CT scan at that point, if they feel like it's helping and there's no plan to go to surgery. But if it only helps a little, or if they don't respond, but CRS is still a possible diagnosis, you can get a CT scan at that point. Because if there is disease present, especially after treatment, they may possibly benefit from sinus surgery. However, it can be tough when these scans come back negative, because, like I was saying in the beginning, some patients have been convinced their whole life that their sinuses are the cause of their problems, and a lot of them are not happy when you tell them this isn't true. So I know it's easier said than done, but in my experience, you need to spend a little extra time with these patients. And I know that can be difficult in a very busy clinic, but spend that time showing them their negative scan, explaining why you don't believe their sinuses are the cause of their issues. And I like to use the word masquerading, as in symptoms of other diseases can masquerade as sinus disease. And then the patients believe that they are suffering and you want to help them. But, you're letting them know that the sinus is not what is causing their problems, and we need to find a different diagnosis. So just to rehash the way to diagnose CRS one more time, when these patients come into your clinic and you kind of are deciding which way to go with them. So the diagnosis starts with 2 of these 4 symptoms present for over 12 weeks. Then the diagnosis is confirmed with CT or endoscopy. If it's not confirmed, like what we are sort of focusing on this lecture, then another diagnosis should be sought after, such as migraine. And we'll talk about some other things that could also be on your differential. But let's quickly just go over what to do if CRS is confirmed. So the evidence that we currently have tells us to recommend saline rinses and intranasal corticosteroids as the first-line treatment. If that doesn't work, you can try a 3-week or less course of antibiotics, plus or minus oral steroids. And if that doesn't work, consider endoscopic sinus surgery with continued post-op medical management, of course, so continued saline rinses, or some people put budesonide in. So here are some other disorders that can cause facial pain. So aside from tension, headache, or migraine or other primary headache disorders, which are very common, you can also think about dental disease, trigeminal neuralgia, TMJ, allergies. So each of these obviously has their own separate associated symptoms or, presenting symptoms, and those can be hashed out in the history. But I do think it's important to have some type of differential in your head. Your patients will definitely ask, well, what else could it be? When you tell them it's not sinusitis, so you can at least have a differential. And if you feel comfortable potentially treating some of these things, that's great. Or if you do not, you can at least kind of point them in the right direction. Another that I would put on this is OSA. So some patients, who get poor sleep have undiagnosed or untreated OSA can definitely wake up with a lot of facial pressure. So that should also be on the list. But these are just some things I think about if people ask me. So I just wanted to go through 2 quick cases before I finish up, and then I'll leave a little bit of time for any questions. So this is a 38-year-old female who presented to me with diffuse facial pressure. So I'm just going over patients that it was listed that their chief complaint was facial pressure. Their chief complaint was headache. So she said that it was mostly around her eyes, so periorbital, for about 10 years. And then when I asked about other symptoms, she did describe some nasal drainage, postnasal drip, nasal obstruction. She did not have any loss of smell. She reported frequent sinus infections, all treated with antibiotics, and they did seem to improve on antibiotics, but then everything would get worse once she was off the antibiotics. So, and that's what I list at the bottom. The symptoms do not go away in between infections. Maybe they're not as severe, but they are still present. So it didn't really seem like a recurrent acute picture. She did have asthma, and her asthma was exacerbated by sinus infections. She did also have allergies and underwent allergy shots for 5 years, which she thought helped. She no longer suffered from itchy nose or watery eyes or sneezing, but she still had these other symptoms. So, this is an interesting case because a lot of our patients do have overlapping pathologies, and you kind of have to work out what symptoms are from what disease and how to treat those. So besides for multiple courses of antibiotics, I always ask the time course to see if they've been on kind of a longer time course, because when we looked at the algorithm from the ICAR document, you could potentially offer up to 3 weeks. So I do like to ask these patients the longest course of antibiotics they've been on, especially if they seem like a patient who is not ready for sinus surgery. So she'd been on multiple courses, the longest of 10 days. She did try Flonase for an extended period of time and saline rinses. So she kind of tried all the right things. And on nasal endoscopy, she did have evidence of some edema in the middle meatus, no purulence or polyps. So, looking at this, she did have symptoms that diagnosed CRS and also some objective findings. So since she didn't have any polyps, we come here where we recommend saline and intranasal corticosteroids, but she had already tried that. So then the next step is you can recommend a longer course of oral antibiotics, plus or minus oral corticosteroids. And I'm kind of bringing up this case because when we see patients, they're kind of in all different stages of where they've been treated. So it's pretty rare to get someone who has not tried intranasal corticosteroids or something like that. So I just like this algorithm because I can kind of figure out what they've tried before and then get them to the next step instead of, kind of wasting time redoing what's already been done. Now, of course, you do need to make sure that when they said they did saline rinses and intranasal corticosteroids, they actually did that. So just saying it, you don't want to say, oh, okay, then let's do surgery if they've only, tried it for a day or two. So you do need to hash that out. But there are also patients who have been doing those things for months and have no relief. So, it's nice to be able to get to the next step without having them redo what they have already done. So, we talked about, since she was kind of at this point on the algorithm, I said we could, give you a 3-week course and see if that helps, and get a CAT scan after that, or try some oral antibiotics, or oral corticosteroids. And it was kind of like a conversation, because there's no absolute right way to handle this. It's based on the patient's symptoms. It's based on how the patient feels. So she ended up wanting to think about surgery, so got a CAT scan. Obviously, there is evidence of CRS on the scan. And then she decided to go forward with surgery with post-op medical management and did really well. So, that's a case of someone coming in with facial pressure who did have CRS and kind of what the plan was. But as you can see, there are ways to make sure that the facial pressure is from the sinuses and will improve if you intervene. So this was another patient who came to me with left-sided facial pressure. That was his chief complaint. So he reported it in the frontal orbital region and vertex of the head. He said it kind of felt congested. It was a dull feeling, not throbbing or sharp. I think a lot of the times it is helpful to kind of have them describe the type of pain. Obviously, if you are ruling out trigeminal neuralgia, that's going to be a different type of feeling, like a burning sensation, rather than what you feel, the pressure, congestion you feel in sinus disease. So he described it as happening daily, lasting for a few hours at a time for the past few months. He didn't report any nasal obstruction or sneezing or other allergy symptoms. I asked about tearing, rhinorrhea, kind of autonomic symptoms, and then symptoms of CRS, loss of smell. He didn't describe photophobia or phonophobia. You don't always see that with all migraine patients. He said that Advil helped, antibiotics helped a little, sprays and rinses did not help. No pain with jaw opening, no dental issues. So he kind of asked about TMJ and other things like that. He did report snoring and had not had a sleep study prior. He was overweight. And then when his nasal endoscopy was normal. So again, looking at this, he wasn't, he did have facial pressure. He did actually describe some discharge and stuff like that. So he maybe would fit the criteria for symptoms. He didn't have any objective evidence on nasal endoscopy. But he actually had already come to me with a scan. But I like to bring up this case because there's a question of, well, if they have 2 criteria, maybe, you don't really think that's what's going on, but they do have 2 out of the 4 criteria. The nasal endoscopy is negative. What do you do there? Do you just tell these patients, no, you don't have it? Do you work it up a little bit further? Honestly, I feel like if they have done all the medical management, they're still really suffering, and you do potentially have 2 symptoms, I don't think it's the wrong thing to get a CAT scan, because a negative scan is helpful as well. Then you can tell the patient, this is really not your sinuses. We need to think of another reason. In this case, he had already come to me with this, so it was helpful, but I was thinking, would I have gotten a CAT scan if he didn't have one? And I think for this patient who was, you could tell he was suffering, he really wanted to figure out what was going on. And he did potentially maybe meet the criteria, even though I definitely wasn't sold that it was his sinuses. I thought that a negative scan would have been helpful for decision-making, because, the neurologist would then say, yeah, this is not his sinuses. We can try some other medication. So, but, this is another good example, because he was complaining of pain on the left side of the face, did have and I like how someone just, this hitting the infraorbital nerve there. That's actually a good question that people have brought up before, is that rubbing up against the infraorbital nerve and maybe causing some pressure. And, I think that when the bony canal is intact, which it is in this patient, then it seems like probably a little cyst sitting in that area would not be kind of rubbing up against, the nerve through the bone to really cause that amount of pain. So, it is definitely something to think about, but I wouldn't, kind of do that as first line. Like, I would probably have him, and you'll see what we end up doing with him, but I would probably have him, speak to a neurologist or be treated for other things first before offering removing the cyst. Because if it was kind of like more invasive into the infraorbital canal, I could see that. But with the bony wall intact and kind of just sitting against it, it wouldn't be the first thing that I would recommend to treat his facial pressure. But it's a very good pickup there. So he, for the algorithm here, confirmed the diagnosis. He had a mucus retention cyst, but not obvious sinus disease. So we considered alternative diagnoses. So he actually had already been referred to neurology. So I thought that was interesting because I was able to pull up what they said. So they did want to get a sleep study to make sure that poor sleep was not contributing to his headache, which I think makes sense. It used an abortive medication, a triptan, and then talked about some of the preventative medications that they would use. There's a lot of them out there. I have a list of them. At UCSF, they start with Topamax and then do valproate and kind of, figure out what works best. They also, talked about Botox, which I've seen a lot of patients use and have good outcomes with, and a daily headache diary. So the question that I will get is, how much of this will I do, or do I just, send them back to their PCP or their neurologist? How I feel is that I feel comfortable if I think that it might be a migraine, to give these patients triptans just to tell them to use that when they feel a headache coming on, just to see if it helps, because that could be good information for their PCP or neurologist. I don't tend to prescribe preventative medication, and mostly just because this is something that needs to be monitored. You might need to try a couple different medications before you find one that helps. And, with the side effects and everything, I just think that, my practice is busy enough with sinus things that I don't really have the bandwidth to take care of migraine as well. But I think that if that is something you want to do, and you feel comfortable with those medications, it's totally fine. But what I tend to do is tell them to start a diary, see if triptans help while they're waiting to see someone for their headache, either their PCP or their neurologist. And that's kind of where I stop it. But, people do things differently. Some people won't even prescribe triptans. They'll just refer. And this is just to my point, this is a list of all of the preventative therapies that you could use. And, we're busy with, as otolaryngologists, that I don't think that we have room in our clinics for these type of patients, but, if you do, then that's great. So for my conclusions, headache or facial pain in the setting of a normal exam in CT, you should think of other causes, the most common one being a headache disorder. And remember that acute rhinosinusitis can definitely cause facial pain, but this resolves in less than a month. And chronic facial pain thought to be due to sinus disease needs to be confirmed by subjective criteria, and then also objectively, usually with a CT scan. So surgery for facial pain related to CRS can improve this symptom. So we need to remember that we can help these patients with facial pressure if it is related to their sinuses, but the patients must be screened carefully and they must have realistic expectations. You remember it can be difficult to convince patients without sinusitis that sinus surgery is not going to help their facial pressure if they've spent many years or their lifetime thinking that their issues were sinus related. So if you can, plan to spend a little extra time with these patients explaining why their sinus surgery for their sinuses is not going to help their problems, and why you are going to maybe refer them elsewhere. So that is all I have, and thank you very much for listening, and maybe we have a little bit of time for some questions.
Well, thank you guys, and enjoy having you here. And hopefully we'll see you tomorrow. Tomorrow is going to be a live session about advanced endoscopic surgery, and I think you will enjoy it. Have a nice evening. Thank you.